We're going to go through just some updates and kind of where things stand. I know many of you, all of you, have been submitting your Pass 1 projects and information for the regional health plan, and so part of the goal today is to show you where we are as a region collaboratively, and I know many of you have been talking in the room anyway, so you're familiar with what your partners are doing, but I want to make sure that everybody has an opportunity to see how we're doing in the region. If you have a question, just raise your hand. I'll be happy to take it during the time, but we'll also have a time for questions toward the end. And as always, we are videoing the meeting, and so those that couldn't make it, either from your team or from other teams, we will send out a link to the video and audio file. I think probably Monday morning we'll have it out, maybe a little bit after that, but we'll get it out maybe Tuesday. We'll get it out as soon as we can so that you can share that with your folks and have it available as you need it. So again, we're going to record that. So here's kind of where we're heading with today. I want to talk a little bit about the plan update, where it looks like in the region, talk about where we look like for Pass 1, and then really Pass 2, how that works, whether we're going to get there, the status of the region on Pass 2, how the money is divided up, those kind of things. Some common questions that I've been getting over the past few weeks that many of you are asking, so I want to make sure we address these in the open public meeting so that many folks can benefit from it. What the new timelines are, and then just an opportunity for you guys to ask questions and give me some feedback on where you guys are and what kind of questions you have. So we'll just jump right into it. As you know, we did the community needs assessment, and really these were the 6 main items that came up on the community needs assessment. You've all seen this chart, but I just wanted to highlight it again. And I think every project touches on at least one of these, but many of your projects touch on multiple ones of these, and so that's really good to see the coordination between the community needs. So I won't spend a lot of time on this. I just wanted to remind you guys this is the goal, or the needs that we're trying to address, and obviously the goals that we have for the regional health plan is a very broad level. We want to improve the quality of care and patient satisfaction, improve the health of the populations that we serve, reduce the cost of care and be efficient with the way that we deliver health care in Northeast Texas, and especially in our region, improve access to healthcare services, both physical and the behavioral and mental health side, as a major emphasis in our region. So here's where we stand in Pass 1. We currently have 5 local mental health authorities participating, 7 public hospitals, 1 academic health science center, 11 private hospitals, and 2 public health departments at the local level in Pass 1. And so we'll talk a little bit about how Pass 2 works. But in Pass 1, that's where we are. A number of other providers are participating as collaborative partners, and not maybe a performing provider on their own, but are joining with other entities to do projects. And so I know a number of you have relationship with your FQHCs, with a number of other entities in your community that are participating as a collaborative partner. And so really pleased with how this has come out, and really pleased with the hard work you guys have been doing in the regions to develop relationships with your partners. And so I just wanted to give you, this is very good, by the way, compared to a lot of regions. And so this is something to be very proud of for you guys. This is also another number, some good news. It's always good to give good news on a Friday morning when it's rainy. But our goal in the region, we were required to have at least 8 projects from categories 1 and 2, with half of those being from category 2. We're right now sitting at 73 projects combined for categories 1 and 2, and so that's very, very good. Some of these numbers may change depending on how some of the final projects are being worked on at this point, but we feel pretty confident. I mean, we're going to exceed our 8 project minimum goal. Some of our institutions individually have exceeded that, have been really aggressive with their projects. But that's a really impressive number. And I'll say, just as we've been looking at these project plans and we've been looking at these workbooks, a lot of these projects involve multiple partners. And so what we've been interested to see is that a lot of these are just not isolated within one institution's projects. They really are reaching out and collaborating with other entities. So this is a very busy slide, I know, but I just wanted to remind you, the other requirement for Pass 1 was that project valuation for every performing provider complies with these funding distributions. And so suffice it to say, if you passed in your workbook, which everybody in the room did, if you passed in your workbook, you met these requirements. And so I'll just say that the region as a whole has met these requirements for Pass 1 of keeping their funding levels distributed across these categories. And so nothing major to say there except congratulations that you met those requirements. So here's where we are with Past 1. Our next steps, obviously we at the anchor level are reviewing projects and workbooks to make sure they comply with the anchor checklist. That anchor checklist is a really high level check of projects. So it doesn't really get into is your project good? Is it high quality? Those kind of things. I think they all are. But it really looks at, did you meet minimum requirements? Did you put the right outcome domains on your category 3? Does everything relate back to category 3? You know, those kind of things. And so we're working through that. Many of you I've already talked to about things that I've seen that may need to be corrected or revisions, and the rest of you, we're getting there as we work through these project plans. But in general, I would say that the vast majority of folks are doing very, very well with complying with regional, with the PFM requirements for your Past 1 projects. The next big step is we at some point, HHSC requires us to lock Past 1 workbooks. And the reason for that is everything we do post Past 1, so Past 2 and any additional passes that come for the region, are all predicated on what happens in that Past 1 workbook. So at some point, the regions have to actually just lock them down and say no more changes to workbooks. Right now, we're looking at October 31, and the reason is we need to post Past 1 projects for public comment November 5th, but we've got to begin calculating Past 2 allocations to providers. And so we're looking at this point about locking workbooks on October 31. I don't think that's going to be a problem for most of you in the room, but if it is, let me know and we can try to work with that. But it's going to take us a few days to get the Past 2 allocations out, and we want to get those to you as soon as we can. So the next real big step after we do that, we're going to post it. We have to post them for public comment. So there's a 5-day public comment period that we'll post everybody's projects on, and then we'll hold a public hearing on Past 1 projects on November 9th. We're looking at locations. We're looking at Mount Pleasant. We're trying to keep everything above I-20 because that's where most of our providers tend to be located. But we're looking at Mount Pleasant for November 9th. And then, of course, the big goal is to be able to submit these to HHSC by November 16th. That's the firm, hard deadline that we must meet. I think we'll be a couple days early on that, but we're going to be pretty close to the November 16th deadline. Okay, so Past 2, the big question that I get probably more than anything else. These are the requirements, and I don't know why my numbers didn't change, so it's supposed to be 1, 2, 3. But in order to advance to Past 2, regions must meet each of these requirements. So all Past 1 requirements, those are the slides we've just talked about. We've met those. We also have to meet broad hospital participation targets. That's the minimum private participation in the regional health plan that's required. And then major safety net hospital participation, which is the 2 major safety net hospitals, have to be in the plan under DESRIP. And so we'll kind of talk where we are but with that. For the broad hospital participation requirement, that is 15% of the private hospital allocation has to be funded. We're at 66% right now. So we've done well on that. The private hospitals have been working very hard with their public partners for IGT, and so this is a very good number. Considering that the goal and the requirement from CMS and HHC was 15%. This demonstrates a high level of private participation in the regional health plan. The second requirement is that the major safety nets have to participate at some level in DESRIP, which means they have to have a full DESRIP plan in place. We have 2 major safety net institutions in our region, Good Shepherd Medical Center in Longview and Mother Frances Hospital in Tyler. Both of those have to be in the regional health plan for the region to advance to Past 2. And we really think at this point that we expect the region will meet this requirement and move to Past 2. In fact, we're progressing as if that's going to be met. And I know my Good Shepherd friends are sort of pointing each other, but we are there's some final details being worked on the Good Shepherd end, but we feel very confident we're going to be there. So we're going to move forward in the region toward Past 2 for that. And so obviously the region wants to thank Mother Frances and Good Shepherd for their hard work. This is not an easy task to get in and to be working on those on the private hospital side. And they've been very good partners and been working very hard to make sure they've got very good plans in place for the regional health plan. Okay, so Past 2, how does it work? I do think we'll be in Past 2, and so we need to begin to have the process in place to allocate Past 2 funds to all of our partners. And so these formulas are driven by the Program Funding and Mechanics Protocol, which many of you, hopefully all of you, have seen at this point. But unused amount, any amount that was not used in Pass 1, is allocated along this formula. So 15% is reserved for hospitals that were not a part of Pass 1. And so these are essentially hospitals that may not have participated in the former UPL program. They may not have participated in DISH. For whatever reason, they did not have a Pass 1 allocation. And so I think I know of 2 hospitals in our region that will intend to be in Pass 2, but did not have a Pass 1 allocation. So that's where the 15% will go. 10% is reserved for physician practices that are not affiliated with an academic health science center. So physician groups that are part of another hospital system, there's an allocation specifically reserved to them. The remaining 75% is reserved for performing providers that did participate in Pass 1. And so that's sort of the broad categories of funding, and we can talk specifically about how these dollars are allocated within those groups. And so in the first 2 cases with the hospital providers that didn't participate in Pass 1 and the physician practice plans that are not affiliated with an academic health science center, it's a simple division that's done. So if you take the total amount of dollars that are available in Pass 2, you multiply it by 15%, for example, and you come out with a number, and you divide that number by the number of hospitals that desire to participate that did not have an allocation in Pass 1, and that's how much allocation each individual institution gets. The same is true for the physician practice plan, and so these are just simple divisions in the program funding and mechanics protocol. The third bullet, the 75% that's reserved for performing providers that were in the Pass 1 allocations, is a little bit more complicated, but essentially, again, you start with what money was left over, you multiply it by 75%, you take that number and you look at your institution's relative amount of DESRIP you did in Pass 1, and you multiply those 2 numbers together and you end up with the allocation to your institution. And so this is very workbook driven, so don't feel like you have to do all these calculations. What we're going to end up doing, this is why we have to lock Pass 1 workbooks, because everything is calculated based on what's in your workbook in Pass 1. So what we'll essentially do is we've got an anchor workbook that will preload everything that you've sent in on your Pass 1 workbooks, and it will spit out these numbers, and we will turn those around to you guys. We'll have to do some cleaning up of it to make sure that it's going to the right institutions and TPI numbers are correct and all those kind of things. But essentially these calculations are done automatically through workbooks, but your institution will receive an institution-specific allocation for Pass 2 just as you receive for Pass 1. So you'll know what your exact number is. And then you'll get a Pass 2 workbook, and so that'll be the hard work on the anchors part, is trying to develop, take the aggregate numbers that come from the anchor workbook and populate individual hospital specific or individual performing provider specific workbooks. But you'll get a separate workbook with your new Pass 2 allocation. Does that make sense to everybody? Is there, Mary Elizabeth?
So for those hospitals that didn't participate in Pass 1, or the physician practices that were not eligible to participate in Pass 1, is there something they have to do prior to this allocation to let you know that they want to participate?
And so let me know. That would be helpful. The question was just for the... Yeah. Okay. So just for the those that weren't here today, so I can get this on the feed. But so the question was for those that were not a hospital, they were a hospital that did not participate in Pass 1, or they're a physician practice plan, not part of an academic health science, so they need to let us know that they want to participate. I would say yes. Please let me know, just so we know how to populate those. This is going to populate based on TPI numbers and those things. So essentially, I'll need those. So what we'll do as a region is notify our stakeholders. We're moving to Pass 2. And I need, if you intend to participate in one of those 2 groups, I need TPI numbers. I need that information from you. So you will see a request for information from me on that. But you can always let me know early, which helps.
If you have a long list of TPI numbers, I probably need to
select one. Yeah. Yeah. So if you have multiple TPI numbers, which has been a problem throughout the region in Pass 1 especially, I think essentially you pick the TPI number that makes most sense for that institution. And so, of course, we'll distribute Pass 2 workbooks by November 5th. I'm going to hope to get this out to you earlier than that, but certainly by November 5th, you'll have a Pass 2 workbook that's specific to your institution so you can begin the work on your projects into Pass 2. Dr. Levine.
That third category is performance providers, all performance providers, hospitals, non-hospital performance providers, essentially anyone basically come off into that. And that partly determined by whether your desert is.
Right. So the question was that third, the 75% that's reserved for performing providers in Pass 1, is that all performing providers that participated in Pass 1? And the answer is yes. So non-hospitals, so the behavioral health centers, the local mental health, the local public health departments, the hospitals, everybody is sort of wrapped up into that last category if you participated in Pass 1. The first two categories, the hospital providers that didn't participate in Pass 1 and the physician practice plans, those are sort of new entrants into the game, and so that's reserved for them in that piece. So project requirements for Pass 2, it's very similar to Pass 1. The important thing is what's highlighted up there. It's new Deseret projects. And so a couple questions that I have been getting is, well, can I supplement a Pass 1 project? Can I expand it, add another dimension to it, and increase the value of that project by doing some of those additional services? And really what HHSC and CMS are looking for are new projects that continue to meet the community needs assessment. So certainly if you get another $1 million in Pass 2 allocation, they really don't want to see you allocating that $1 million to a Pass 1 project and upping that value. This is for new projects that complement the regional health plan that was developed in Pass 1 and address those outstanding community needs. So just like in Pass 1, your projects have to be implemented by one single performing provider, but in Pass 2, any provider can collaborate with any other provider on allocation. And for our region, because we were a Tier 3 region, that was the case in Pass 1. In some parts of the state, that was not the case, that only certain hospitals could collaborate. In our region, we were collaborating in Pass 1, you can collaborate in Pass 2. But the important thing, and we'll talk a little bit more about what that means here in a second, but any performing provider can collaborate with their Pass 2 allocations. And then, of course, your projects must still comply with your planning protocol requirements and have a source of IGT to be included in the plan. So, and I've had to remind folks about this, but really, there's three components, three financial components that have to be met for you to have a project, right? You have to have allocation. So your allocation is what gets you access to participating in the regional health plan. You have to value your project, right? So your project has to have a value that is within your allocation. And third, you have to have IGT. So if you don't have an allocation under Pass 1 or Pass 2, or if your allocation isn't sufficient to do all the projects you want to do, you don't have an opportunity to submit those projects. If you don't have IGT, then regardless of your allocation that you have, you can't submit a project for inclusion in the regional health plan because it has to be matched with IGT. And so it's helpful to keep that in mind because I've had one or two institutions send me a project with no IGT, and we've had to remind them, and unless you have an IGT match, this is not a project. We can't include this in the regional health plan. So we'll talk about the collaboration piece here in a minute, but I want to go through some common questions that I've been getting for months, and really especially as these have been closer and closer to being project submission time. Plan certification. So many of you have asked, when do I sign? How do I certify that we're participating? All those things. If you are an entity that's either providing IGT or you're an entity that's going to be receiving pool payments, so you're going to be receiving payments under the waiver, you have to sign the Section 6 certification section of the RHP plan template. You'll decide who the best person in your institution is to sign for that. It's whoever has the legal authority to sign for your institution and to certify that everything in the regional health plan related to your institution is true. So that's what you're signing for, but we don't need that till final plan submission, which is sometime in December. No later than December 31, but I think our region will have that done earlier. If you're fulfilling multiple roles under the waiver, and many of you are, so if you are an IGT contributor and you are a performing provider, one person can sign for both. You can have different people sign for each piece of it, but essentially you're certifying both to your participation as an IGT contributor and your participation as a performing provider. And so just know that's what you're certifying, but it's not needed until December 31. What we will likely have to do, one of the requirements in the regional health plan is that any certifications that are submitted we're probably going to have these on one page essentially. So we may have to have a regional meeting, or I may get to travel to see a lot of you guys and get these signed on one page, but we'll work that out as we get closer to December. But many of you have thought, do I need to get this done now? The answer is no. We have a little bit of time to have those certifications done. Right, and so the question was, does this include any subcontracts that you may have with entities to help carry out the plan? And the answer is no. So these are only the entities that are actually the performing provider or the actual IGT contributor, not any collaborative partnerships you have with folks to carry out work under the waiver. Affiliation agreements. So certifications is the term used for your participation in the regional health plan. Affiliations is the state's term for the agreements to provide IGT either for uncompensated care or for DESRIP. And so many of you already have these in place because you were participating in the UPL program for a while, so you're familiar with these. But those forms are due to HHSC now November 9th. They were due today, and that's been extended by a couple weeks. And so you have through November 9th to get your UC tools in and your DESRIP tools. If you have an affiliation agreement and it's only for the purposes of DESRIP, you're not having affiliation for UC, you have additional time past November 9th because that affiliation is required with submission to the final regional health plan in December. I would suggest getting it in early because those require review from HHSC and they want those in place. So the earlier the better. If you know you have an affiliation, get it in because that's really going to save you a lot of time on the back end. The one big thing that just needs to be pointed out on here is this third bullet point. If you're a governmental entity and you are providing IGT to a private entity, that affiliation agreement has to be considered in an open meeting of your governing board. So just know for your purposes internally of posting your meetings and making sure your governing board has this on their agenda, that is a requirement of governmental entities. Okay, collaborative agreements, and this is probably where I've gotten more questions than anything else in the regional health plan. So as you know, under the program funding and mechanics protocol, entities, and we'll just for the sake of simplicity know that in Region 1 all the entities can collaborate at any time, but entities can collaborate with each other on allocation and they can collaborate with each other on carrying out the project. But for allocation purposes, if you intend to share your allocation with another entity for the purposes of regional transformation, so a hospital has allocation and they're going to work with the behavioral health center to do a crisis stabilization unit, for example, and that hospital wants to, that behavioral health center needs allocation to make that project happen. The hospital can give allocation to that behavioral health center. Any two entities can do that. But to do that, you have to have an agreement in place, a written agreement that says that this transaction was entered into freely and it's for the purposes of transformational projects. So there's nothing magic to that agreement. There's not a standard form that's out on HHC's website. But I would look back at the PFM and look at the language that describes this, and it's pretty much that second bullet point, but that it's entered into freely and it's for the purposes of transformation. You obviously still have to have IGT. So, yes, sir.
Saying agreement, are you talking about a legal type of agreement or just a letter of support? Or what?
So the question was, is the agreement just a letter of support? Is it a legal contract? Is it those kind of things? It's very informal in the PFM, and so your affiliation agreements for IGT are not informal. They're very structured, and there's a form that HHC wants to use. I've seen some of these across the region. They tend to be a couple paragraphs that just say, Entity A desires to work with Entity B on a collaborative project, and we agree to collaborate on the project and share allocation, and it's signed by both parties. And that tends to take care, but it needs to be signed by both parties because, and this is important, if you're doing this already, and I know a number of you in the room are, this shows up in your workbook, and so I would go back to your workbook where you are sharing that allocation, and just make sure that for every time that you show an allocation that's being shared, you have a signed form allowing that. If you are a multi-hospital system and you are sharing allocation within your system and your other hospitals are separate and distinct entities that have their own allocation, you got to sign an agreement between your own hospitals to get that allocation over. So I know that was a question that would likely come up. Yes, sir. So the question was, if you're collaborating on multiple projects, I guess with the same partner, do you have to have multiple agreements or one? I think it's how you structure the agreement. If you write one agreement that covers we're going to collaborate on multiple projects and here's how it's going to work, I think that's sufficient. They just want to see that when somebody else's allocation ends up in your workbook, that was an agreed upon relationship, that I mean, there's not really a mechanism for you to take the allocation, but they just want to make sure that there was a legitimately signed agreement to share that allocation. I think it's up to you how you structure that. Unused. So here's another question I get all the time: is what do we do if after pass 2 there's still money left over? The PFM doesn't. It really just says the region will collaborate and figure out what to do with it. So what we'll essentially do is after pass 2, as an anchor, we'll sit down and look at what's left available, and we'll have to sit down with the performing providers and especially the IGT contributors and say, how does this allocation need to be distributed across the region? Who has IGT still remaining? Who has projects they would still like to do that doesn't have IGT? And try to create that match in that situation. And so, if we get to this point, if all the allocation isn't spent in pass 1 and pass 2, that's essentially how that will work. Again, all the projects under any other pass will have to still comply with all of the other requirements in the waiver about what's in your project, the components. They have to be new projects, but essentially that's the structure for post pass 2, or I don't know whether we're calling it a third pass or what we're calling it, but essentially that'll how it work. It'll be really driven primarily by IGT contributors and performing providers, but again, IGT, as you know, is scarce in the region, and so if IGT contributors are going to be key in that additional pass. They're key in every pass, but they're going to be especially key in that third pass. So high-level deadlines where we are. These are the 3 deadlines that we cannot move. These are the requirements and the agreements between HHSC and CMS. So October 31, I have to submit sections 1, 2, and 3 to HHSC. That is the sections that just describe at a high level the regional health plan, talks about who's participating in the regional health plan, and a summary of projects. And then finally, the community needs assessment is in that piece as well. November 16th is the hard deadline for Pass 1 projects. That includes, I don't know if I put it on here, your Pass 1 workbook, the anchors checklist, but most importantly, if you've put a project in there, you're saying you have IGT for that project, and it's in your workbook and you've got IGT listed. So that IGT needs to be firm, because once those workbooks are locked, any changes to that will have dramatic implications on the region. So if your IGT is not locked up in that place, you need to let me know, because we need to do some work before we lock those workbooks down.
Daniel, when we have to list the people that we're going to get IGT from in that workbook piece, is that only the people that we're using for the IGT for Pass 1, or if we're anticipating expanding the list of people we might be getting IGT from, do they need to be on that Pass 1 workbook?
Yeah, so the question was, on your Pass 1 workbook, are you listing just your IGT contributors for your Pass 1 projects or other IGT contributors you expect to have? Your Pass 1 workbook lists your IGT contributors for your Pass 1 projects. Your Pass 2 workbook will show your IGT contributors for your Pass 2 projects. So when the final regional health plan is submitted, it'll be both of those workbooks rolled up into the regional health plan. So when you submit your Pass 1 projects and your Pass 1 workbook, you are saying, I have these projects, I have these IGT contributors lined up, and I have commitments to help fund these projects at these levels so that these projects go forward. You're going to do the same thing in Pass 2. So it may be the same IGT contributors in Pass 2. It may be different ones, but you're going to list for those projects in Pass 2, you're going to list their corresponding IGT contributor in them. And then, of course, December 31 is the deadline for the complete RHP plan, the full plan, everything's in there. I was telling Rich earlier today, I actually think we're going to be early on December 31, because I think we'll be pretty close to November 16th for the Pass 1 deadline, but I really do think that our region is significantly ahead of the game for the final submission, which is a benefit to the region, as we've talked about before, because it triggers the review period earlier from HHSC's standpoint, and it allows you to get working on your projects and get them approved a lot faster than if we come in with the flood of projects on December 31. So I really do appreciate, I know that's been a lot of work for you guys and a lot of hard work and time away from your other responsibilities at your institutions, but the effort that you guys have put into so far has meant that we're going to be significantly ahead of that December 31 deadline, and that's a great advantage to you as providers and to the region as a whole. Obviously, and that's the last little tag that I always like to say is, but with regional consensus we can move faster, and you guys have been moving faster, which I appreciate very much. These are just sort of the more drawn-out deadlines of what's going to happen month by month. So November, we've talked about some of these already. Past 2 workbooks will be due to you no later than November 5th. We'll post public comment for projects in Past 1 the 5th through the 9th. We'll have a public hearing on Past 1 projects November 9th. And on November 16th, we'll submit those projects to HHSC. And then this is the new one that we haven't done, but your plans for Past 2 will be due on November 20th. That gives us enough time to start doing the processes we have to do to get those certified and done. And I know Thanksgiving is in there somewhere, so hopefully we all have a chance to see our families. Yes, sir.
What happens if not all projects get approved?
So they won't be doing their review period. So the question was, what happens if a project doesn't get approved? Does that allocation move from Past 1 to Past 2? HHSC's review period doesn't start until everything has been submitted. So they're going to be reviewing your projects in full, and it's a question a lot of us have been asking. I don't know there's a firm answer on. So if your project doesn't happen, I think what HHSC is expecting to do is to work with that individual performing provider to either revise their plan, to have another plan to submit in place of the plan that was rejected. But they're going to be I don't see them shifting allocations around again, because again, it has so much of a huge impact on the region as a whole. So what I've heard HHSC suggest to other performing providers is, have some projects in mind in case something happens and you need to swap out projects, but they'll need to be swapped out in a way that doesn't impact your workbook. So if you have a project that's valued at $100,000, for example, whatever you replace it with needs to be valued at $100,000 as well. Yes, ma'am. Yes, we're going to get that here in just a second. So yeah, the question was public hearing process for Past 2, and we'll get that on next slide. Dr. Levine.
Am I confusing the November 5th day with when the actual figures will be available for Past 2 allocation?
So the question was, what happens on November 5th?
Yeah, and then if it's not Past 2 allocation, when will everyone know about available?
So November 5th is the date that you'll know your specific allocation for your hospital or your institution in Past 2. So that's what that deadline is. That's an anchor deadline. That's a deadline I have to get that out to you by, and we'll have it to you, of course, by that date. We'll try to do it earlier, but we'll have it to you for sure then. December will be busy, primarily with public meetings and public hearings, but the 7th to the 14th is really an opportunity for us just to see is there going to be an additional pass, and that should kind of go relatively quickly. No later than the 17th to the 21st, anchors are required to post the final RHP plan for public comment and public hearing on December 21st. These deadlines, I think in December will move quite a bit, and we'll continue to work with you guys, especially our Friday calls. As we get closer and closer to these deadlines, if it looks like the region is ready to submit earlier than this, then with regional consensus, that's what we'll do. But we'll take our cue from you. If you're not ready, we won't submit. But by these are the last opportunities we have. These are the final deadlines that we have to meet in order to comply with the requirements of the waiver. And so, assuming that we submit on the latest possible dates, then HHSC's review period begins January 2nd, and CMS's 45-day review period begins February 5th. And so, let's talk about that just for a second. I've had a lot of questions about what happens during the review period. Am I going to hear from anybody? Should I expect to hear comments from HHSC? And the answer is yes. You should expect to hear comments from HHSC, and you should expect to hear comments from CMS regarding your projects. What we expect to happen and what we've been told will happen is HHSC will begin their review, and they'll have their quality experts reviewing your projects for content. We will have already done our anchor review, which looks at the requirements of the waiver and have they all been met. HHSC will review that as well to make sure that piece is correct. But they'll focus a lot on your quality outcomes in your projects. They'll focus a lot on is this a transformative project, all those kind of things. And you're going to hear back from them probably through the anchor, but certainly you will hear from HHSC on comments or suggestions they have on your projects, questions they have, additional need for information. What I'm told is that during this 30-day review period, when they communicate, they'll give you some timelines and deadlines of when they need to hear back from you so they can keep with these timelines in place. So you should be expecting to hear from HHSC and them say, you know, we have a few questions on your project. We don't understand this piece of it. You know, can you get back to us within 5 days or something and let us know the additional information we've required? Or you may hear from them and say, you know, we just don't think that your metric is aggressive enough for the value of your project and for what you're trying to accomplish. We need you to revise this part of your project, and they will give you a certain amount of time to make that happen in. And I would expect that to happen at CMS as well. HHSC is certifying at the end of their review period that they believe that all these projects meet the requirements of the waiver, are transformative, are appropriate, the metrics are appropriate, the outcome domains are appropriate, but we certainly expect our federal partners to review these projects as well. And I think you will expect to hear from CMS about suggestions they have or revisions they need or even additional information they have on your projects. So these will be a lot of back and forth on that in those 2 review periods. And I know everybody in the room has been very good about responding to requests for information and responding to those kind of things. So I don't expect any concerns with this, but just be expecting that as they review that project. Yes, sir.
So am I interpreting you to say that the anchor's role in reviewing the content of the individual plans is relatively minor? That's really going to be done at the state?
Yeah, so Rich's question was, what is the anchor's role in reviewing projects as they've come in? So our specific role is to complete the checklist for every project, and the checklist is, I've emailed that out, and if you've seen it, it's focused mainly on the requirements of the waiver. So things like, as basic as is the narrative within the page limit guidelines, but also things like, is there an outcome domain for a Category 3 outcome domain for every project? Is there metrics in there? Are all the financial measurements appropriately distributed across the items? Not so much a quality review check of, you know, is this project, is the metric aggressive enough? Those kind of things are really HHSC's call, not ours. Now, while we're reviewing it, if we notice something that, you know, we think we may give you a heads up about it, but you know, we will not strike projects from the regional health plan. We will work with you if there's a problem. If for example, you have a project that just doesn't meet the requirements of the waiver, you know, you have no Category 3 outcome to it. We're going to call you and say, there's no Category 3 outcome to your project, and if we submit this, I can't submit this because HHSC will reject the entire plan as a result of this. So we either need to get a Category 3 piece in there, or or the project has to be dropped for that purpose. But for quality reasons, we're not going to strike projects.
What about some components like an allocation agreement or an IGT agreement or something like that? Are y'all going to review that?
So we will review to ensure that every project has an IGT match associated with it, because that's one of the checklist requirements. We will review to make sure that you didn't exceed your allocation. Right. So if you have a collaboration in place and you are agreeing to share allocation with someone else, we'll have to see, because you will have exceeded your original allocation, we'll have to see that collaboration agreement is in place. So those are the sort of the basic review periods that we're doing. We're working through it. I wouldn't say we're halfway through it, but we're working through it.
Just for our own plan,
Yeah, it'll probably be, I would say it'll be late next week or early the following. I mean, we're close, and we may do this earlier than that, but I'm hesitant to put a date on there because as we get into plans, some of them are stronger. I mean, some of them are more, some of them are farther along than others in terms of, most of them don't have too many problems in them, but some of them we have to go back and forth for additional information or style things. But as we finish your institution, we will let you know. I mean, we will let you know where we are with that. So, yes, sir. So the question was, if projects are submitted and they're very similar or identical to each other. What do we expect HHSC or CMS to do about that? You can't have duplicative projects. That's sort of the broad requirement under the waiver. However, if you're serving different populations, you're doing a similar project, but you're serving different populations, that's expected under the waiver, right? Because, I mean, we have 21,000 square miles in this region and 28 counties. There's going to be projects that are very similar to each other across the region, but that are serving different populations. So that's appropriate. HHSC and CMS will look at projects that, if they believe that the project is serving the same population and doing the same thing with them, they will be contacting those two performing providers. What we've been told as anchors is to submit both projects, and HHSC will make the call on how they move forward with those two projects. I haven't seen really that as they've come in. As we've done a quick high level, there are certainly similar projects, and I use behavioral health examples a lot because it's a clear example, but there's been a very collaborative approach in the region on addressing behavioral health needs across the region, and so there are similar projects that have been worked out that serve completely different populations, but that are very similar projects across the region. That's appropriate. I mean, that's a coordinated effort to transform the region in terms of behavioral and mental health services. But if two performing providers are doing the same thing to the same population in the same community, HHSC is they're going to see it as a duplicative project, and they're going to want to talk to those providers about it.
It's my impression that there was a role for the anchor to evaluate or compare similar projects throughout the region for their evaluation of quality. Is that something that y'all would do?
So just for the video, the question was the role of the anchor in reviewing valuation of similar projects throughout the region. So similar to the other issue of duplicative projects, our role is to give you a heads up that we see it, but not to strike it, not to remove it, not to change it, to send it to HHSC, because they're going to make that call on whether HHSC has been very clear to the anchors that we are not to make those calls, and so we'll let you know. I mean, if we see a project that, one institution's doing a primary health care expansion project, and an institution 200 miles away is doing a very similar project, but they're valued, multiples apart from each other, we'll notify you that, you ought to know this is going on, but we're instructed from HHSC to submit those two projects together to HHSC, and they'll make the call on how to resolve the issue. So HHSC will make that call on how they make. So the question was, if HHSC changes the valuation or makes suggestions, and you have to revise it, what do you do? You'll have opportunities to revise it. I think HHSC will be careful about how that impacts the workbooks, because again, that will have moved regions to pass 2, and there'll be allocation that's being assigned there, and so I think they're going to have to take that on a case-by-case basis of how do we resolve the discrepancy in the workbook, because they're going to want as best as possible to ensure that whatever allocation you used remains with that institution, because the second it comes out of your workbook, it impacts the region as a whole in a dramatic way. So, but that's an HHSC call. So again, we are, the anchor is, as we've talked about before, is not an administrator or have authority. We really are a compiler and a convener and I mean, I'm doing a lot of copying and pasting right now of your projects into a full regional health plan. So we'll notify you that we see that, but it'll be up to HHSC and the two performing providers to resolve whatever differences are noticed in there. So that's what we expect on that. Follow-up from today's meeting, of course, we'll send you a link to the video from today's meeting in case you have folks at your institution that weren't able to attend this, or other partners that you have in the community that need to be able to see this. We'll send the slides from today, and then I think many of you have seen this, and it's been circulated over email, but the frequently asked questions document from HHSC is really good, especially when it gets down into project categories and specific questions they've received. So we'll recirculate that to folks in case you haven't had that. There is an upcoming, at least they're talking about scheduling an upcoming webinar with CMS around the issue of how do you benchmark your projects. And so this really looks at moving forward into when you start to begin to implement your project, and you need to be thinking about your benchmark years and how do you gather that data. CMS has offered a quality expert to do a webinar for performing providers to look at the issue of benchmarking. And so as soon as we have dates and times on that, we'll let you know so that you can participate in that if you'd like to. And then, of course, we will continue to do our regional webinars on Fridays at 3:15. And today we won't do one, obviously, because we had a regional meeting. But next Friday we will. And I appreciate you being willing to do a 3:15 on a Friday afternoon webinar. We do it at that time, so our anchor call ends at 3 o'clock. And so we do it at 3:15 so that we can share information from our anchor call with HHSC, with our stakeholders in the region. And so, so just be looking for that again next week. And then finally, if there's, we've taken a lot of questions, but I'm happy to take additional questions or answer anything that you're running into, problems, concerns, questions, anything I can help resolve while we're here together as a group. Anything? Dr. Levine.
Not really a question. I realize we work together in other ways, but nonetheless, as a submitter of Desert projects, I just want to thank you for your leadership in taking it. They're very complicated in helping us all through this process. It's very frustrating, and you've really done a marvelous job in helping us sort of like a herd.
Well, thank you. And I'll tell you, we've mentioned this to you. Thank y'all. And we've mentioned this before, but it's not always obvious because we do work in the same institution. But so our institution serves three very distinct roles. We serve as the anchor, we are a performing provider, and we're an IGT contributor. And very early in the process, Dr. Calhoun came into my office and said, there is a firewall around you, and you are to deal with our own folks just like you deal with everybody else. And so I often don't know what Dr. Levine is doing on the DESRIP side, because we have to communicate just like I communicate with you guys. And so he gets less desirable appointments with me, though, because I reserve the daytime times for my performing providers that are not our institution, and he can get the nights and weekends and early mornings when nobody wants to have conversations. But we have really divided that up very, very clearly. And so many of you have called and said, what are you guys doing on your desert projects, or can I talk about IGT? And I send you other places because I frankly don't know. We're focused on the anchor side of things, but that firewall I think has been very good for me to allow me to focus on the region, and that's really essentially my client, and allow performing providers to collaborate with Dr. Levine and his team, or IGT providers that need IGT to collaborate with Vernon, and I don't have to try to juggle all three balls. So. But just in case y'all, I think most of you have experienced that when I've sent you other places, because I just don't do those roles. But thank you for that. I appreciate it. Anything else? I know we'll wrap up just a little early today on a Friday, and hopefully the rain looks like it's subsided a little bit. So. Okay, well, thank y'all very much. Obviously, you know how to get a hold of me, but just in case, there are all the numbers you might need: my cell phone, my direct line at the office, email addresses. Yep, and they're on there. We talked about that. How you get a hold of me? You can call me anytime. I know a number. If you call me late at night, I'm happy to take your call. You might hear my daughter having a tea party while we're doing that, but I'm happy to take calls with you anytime you need. Just call my cell phone if I'm not in the office, and we're happy to help. So thank y'all for being here. Appreciate it very much.